I'm honored to be with Mary Bird Perkins Cancer Center as we move into May, which is Skin Cancer Awareness Month. I'm going to discuss an incredibly important topic to me and one that I'm certainly passionate about because it impacts each and every one of us: skin cancer awareness and prevention. We recognize that skin cancer is a significant public health concern, with rates of diagnosis continuing to rise globally. It does not discriminate. It affects all ages, backgrounds, and skin types. But the good news is most skin cancers are preventable, and early detection greatly improves outcomes. So today we'll cover the three main types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. Then clinical characteristic and warning signs. There are risk factors. We'll touch on treatment options. And lastly, I'll provide you with the knowledge to protect yourself and help prevent skin cancers. So first of all, what is skin cancer? Skin cancers are caused by damage to the DNA in the cells in the outer layer of skin, caused mainly by ultraviolet radiation, which we'll discuss shortly. And depending on which cell type in the skin has the damaged DNA, will determine which type of skin cancer it becomes. So, just how common is skin cancer? Skin cancer is the most common cancer worldwide. Most people are diagnosed with skin cancer in the United States than all other cancers combined. At least 1 in 5 Americans will develop skin cancer before age 70. In the US, more than 9,500 people are diagnosed with skin cancer daily, and every hour, 2 people die of skin cancer. 90% are caused by ultraviolet radiation. You're going to hear me talk about this throughout the session. So, what is ultraviolet radiation? Simply put, it's the energy produced by the sun. This is a diagram of the sun's electromagnetic spectrum and shows the different wavelengths of light. As you can see in the graphic, ultraviolet rays have a shorter wavelength than visible light, so you can't see them, but your skin can feel them. There are two types of ultraviolet rays that reach the earth and harm the skin. First, UVA rays, and these are the aging rays. They cause wrinkles, age spots, and sun damage. They penetrate glass windows in our car, homes, and offices, and even penetrate through clouds and fog. They make up 95% of the ultraviolet rays that reach the earth, and these are also the rays emitted by tanning beds. Secondly, UVB rays. These are the burning rays causing sunburn. Fortunately, they are blocked by glass windows. But importantly, both cause damage to DNA and skin cells, leading to skin cancers. Now that we've discussed the proven cause and effect of harmful ultraviolet rays and their link to skin cancer, we'll begin our discussion with non-melanoma skin cancers, which includes both basal cell carcinomas and squamous cell carcinomas. Diagnosis of these non-melanoma skin cancers has increased 77% over the last decade. The first one we're going to discuss is basal cell carcinoma. These are incredibly common and are the most common form of skin cancer and the most frequently occurring of all cancers. In the US, 3.6 million cases each year. It originates in the basal or bottom layer of the outer layer of skin. They are most common on the exposed parts of the skin due to ultraviolet exposure. Fortunately, they're localized to the surface of the skin and rarely move to any internal organs. They grow very slowly, and almost all are completely curable. But if left untreated, the lesions grow and become disfiguring and locally invasive, destroying surrounding tissue. So let's take a look at what basal cell carcinomas can look like on your skin. It can be an open sore that doesn't heal, a shiny bump or nodule, a reddish patch, a scar-like area that's flat white, yellow, or waxy in color, or a small pink growth with a rolled edge and indentation in the center. We'll discuss risk factors and treatment options for basal cells when discussing squamous cell carcinoma, since they're very similar. So moving on to squamous cell carcinoma, which is the second most common type of skin cancer in the United States. 1.8 million cases each year, which is about half that of basal cells. It originates from the squamous cells, which line the outermost part of the skin. 40 to 60% of squamous cells originate from untreated actinic keratoses, which are very common precancerous growths that form on the skin. They're caused by ultraviolet rays, so they're found on sun-exposed areas of the body. These are important because 5 to 10% go on to become squamous cells, so it's important to treat them early. They're most frequently treated very easily in the office by freezing them with liquid nitrogen. On the skin, actinic keratoses appear as multiple red scaly bumps on the forehead and scalp and thick scaly red patches on the back of the hand. And just as seen with actinic keratoses, squamous cell carcinomas are most common on the exposed parts of the body due to excessive ultraviolet light exposure. And if not diagnosed and treated early, squamous cells can spread to the lymph nodes and then to other parts of the body. But some squamous cells can occur in non-sun exposed areas, like the mouth, genitalia, and around the fingernails. And in these cases, it's usually associated with human papillomavirus or HPV. So let's take a look at what squamous cells can look like on the skin. It can be a persistent scaly red patch that sometimes crusts or bleeds, an elevated growth with a central depression that occasionally bleeds, a wart-like growth that doesn't heal, or an open sore that doesn't heal. So we've identified what basal cell and squamous cells look like and what their warning signs are. So how do we treat them? Very similar in the early stages, but varies with advanced cases. Almost all can be cured when diagnosed and treated early. Surgery is the gold standard of treatment. With excision, the tumor is cut out using a scalpel with a small margin of normal skin. Or the patient can be referred to a Mohs surgeon, where the surgeon excises the visible tumor with very small margins of normal skin, and then that surgeon examines the tissue under the microscope to see if the margins are clear. If not clear, the surgeon takes more tissue and repeats this process until the margins are clear. This allows for more sparing of normal tissue and minimizes scarring with a cure rate up to 99%. We can treat them with electrodesiccation and curettage, where the site is numbed with lidocaine and scraped with an instrument called a curette, and then cauterized to stop the bleeding and destroy the remaining cancerous cells. Cryosurgery can be used, which is just treating them with liquid nitrogen. And there are many FDA-approved creams, which are chemotherapies or immunotherapies that are used at home and can be easier for the patient. Radiation uses low-energy X-ray beams to destroy the tumor with no need for surgery or anesthesia. And lastly, photodynamic therapy can be used with a topical agent, Levulan, supplied to the affected area, which makes the skin sensitive to the light, and then a blue light is used to activate this area, which destroys the cancerous cells. Advanced basal cells and squamous cells, which means they're locally invasive or they've spread to lymph nodes and/or internal organs. When advanced, they are more dangerous and much more difficult to treat. Fortunately, this is very rare. In basal cells, less than 0.5 become advanced, and in squamous cells, less than 5%. If this happens, it's at this point where dermatologists refer to oncologists who use immunotherapy and targeted therapies. So now that we've discussed non-melanoma skin cancers, let's shift our focus to another very important part of skin awareness. Atypical moles, or dysplastic nevi, certainly deserve our attention. Understanding the characteristics of atypical moles is crucial for early detection. But before talking about atypical moles, let's look at what some normal moles look like. Normal moles should be flesh-colored, tan or brown, with even border and even color. Atypical moles, although benign, have abnormal features clinically and under the microscope. They're worth attention because people with abnormal moles are at an increased risk of developing melanoma, and people with 10 or more have 12 times the risk of melanoma. These develop due to family history and environmental factors. They can occur anywhere on the body, not just sun-exposed areas. At first glance, it can sometimes be tricky to see how an atypical mole differs from a normal mole, but the Skin Cancer Foundation gives us some warning signs to watch for. It's called the ABCDEs for atypical moles and melanoma. A is for asymmetry. If you cut a mole in half, one side should look just like the other. This would be a very asymmetrical mole. B is for border. This mole shows scalloping of the border. C is for color. Multiple colors are a warning sign, especially if you see any blue, black, or red. And D is for diameter or dark. We prefer moles smaller than 6 millimeters, which is about the size of a pencil eraser. But most large moles are benign, so large size alone doesn't make a mole atypical, and a mole that stands out as darker than the other moles is an important marker. E is for evolving. If there's changes in shape, size, or color, or any new symptoms like bleeding, itching, or crusting. And if you notice these warning signs or symptoms, or see anything new, changing, or unusual on your skin, see a dermatologist. The presence of atypical moles doesn't mean that you'll develop melanoma, but it does warrant close monitoring by a dermatologist and the strict use of some protective measures to reduce the risk of melanoma. And lastly, this brings us to melanoma, the most feared and deadliest of the three cancers. Although far less common than basal cell and squamous cell, it gets more attention in the media because of its ability to spread to other organs more rapidly if not treated early, making it the most aggressive of the three forms of skin cancer. Melanoma begins in the cells known as melanocytes, which are the pigment-producing cells. They have damaged DNA that leads to uncontrolled growth of these cells. Let's look at some eye-opening statistics about melanoma. If you have had more than 5 sunburns, your risk of melanoma doubles. In 2024, in the US, more than 200,000 cases of melanoma will be diagnosed. Fortunately, 50% are confined to the top layer of skin, but 50% are invasive, which means it's penetrated to the second layer of skin, and an estimated 8,000 people will die of melanoma. Now, most moles on the skin are harmless, but remember the ABCDEs of atypical moles and melanoma, and look for anything new, changing, or unusual on both sun-exposed and non-sun-exposed areas of the body. There are also some rare forms of melanoma that you should be aware of. Acral lentiginous melanoma. This is the most common type of melanoma found in people of color. It appears in areas rarely sun-exposed, like under the nails and on the soles of the feet or palms of the hands. The musician Bob Marley was diagnosed with acral lentiginous melanoma, which tragically cut his life short at 36. And to make things more complicated, some melanomas do not have any color at all and are called amelanotic melanomas. They may be pinkish looking, normal skin color, or essentially clear and colorless. So what happens at this point? If a lesion is suspicious, a biopsy is done and sent to a dermatopathologist who determines if it's cancerous. And if it is, they want to know how much it's grown and how far it's spread, which is called staging. The 3 most important staging features are first, the depth of the melanoma from the surface of the skin to the deepest margin, because the shallower the melanoma, the better the prognosis. Second, if there is nearby lymph node involvement. And third, if it's spread to distant lymph nodes or other body sites. Once the staging is complete, the treatment can begin. So the types of treatment depend on the stage of the melanoma. Surgery, like basal cell and squamous cell, is the gold standard for early stage melanoma. It requires a wider margin of normal skin with excision compared to basal cell and squamous cells. And if the depth is greater than 1 millimeter from the surface of the skin to the deepest margin, it requires removal of a lymph node to be tested. And if the lymph node is positive, further treatment is required with referral to a surgical oncologist. Chemotherapy uses drugs to kill cancer cells or stop them from growing. With melanoma, this is no longer a first-line treatment due to new and improved treatments. Radiation therapy, it's rarely used to treat primary melanomas, but often used to shrink tumors or relieve symptoms. After years of research, pioneering breakthroughs in treatment, have led to significant progress with advanced melanomas, with improved quality of life and much higher survival rates with the use of immunotherapy, which stimulates a patient's immune system to destroy cancer cells, and targeted therapy, which targets specific proteins found in melanoma cells, which slows down or stops their growth. Unfortunately, everyone thinks melanoma diagnosis is a death sentence, when in fact, melanoma is completely curable when detected and treated early. The 5-year survival rates in the US, if detected early, is 99%. Once it's moved to lymph nodes, it drops down to 74%, and if it's spread to distant organs, it drops down to 35%, which just reinforces how important early detection really is. So we've discussed the 3 types of skin cancers, their clinical characteristics and warning signs, and their treatment. Now, I want to discuss what exactly puts us at risk for getting skin cancer. By far, the highest risk comes from ultraviolet radiation. Again, 90% are caused by ultraviolet rays from the sun and the use of tanning beds. Higher risk if you have a history of previous skin cancers of any type. Much more common in people with fair skin that burns easily and freckles and have light eyes. If you're 50 years of age and older due to cumulative sun exposure, or if you have a weakened immune system due to illness or immunosuppressive medication. Have an increased number of actinic keratoses, and the risk is much higher in organ transplant patients. It's also higher if you've had a family history of first-degree relatives with melanoma, or if you have numerous moles, especially if they are atypical moles. Although these risk factors put us most at risk for developing skin cancer, we have to remember that even if you have darker skin tone and always tan and rarely burn, you can still develop skin cancer. Skin cancer represents less than 5% of all cancers in people of color. So although it's uncommon, it's not impossible. In people of color, skin cancer is often diagnosed later when it's harder to treat and is associated with the worst prognosis. So why is it diagnosed later? There's several reasons. The first is because it's much less common in people of color, so there's less public awareness. Even among physicians, there's a lower index of suspicion. Skin cancers in people of color are sometimes in areas where there's no sun exposure, such as the palms, soles, and under the nails, so they're less suspicious to people. Basal cells in fair-skinned people are usually pink-colored nodules, and that's what we see in all of the pictures of basal cells. But in people of color, 50% are dark in color and much easier to miss. Okay, one of the biggest take-home messages of the session is what you can do on a daily basis to minimize the risk of skin cancer. First and foremost is sunscreen. Everyone, every day. According to a recent survey by the Skin Cancer Foundation, only around 10% of Americans use sunscreen daily. And if that's not shocking enough, nearly 50% admit they never use sunscreen at all. 2 studies showed that melanoma was reduced by 50% and squamous cell by 40% in those who use sunscreen daily. The Skin Cancer Foundation recommends that sunscreens be water resistant, broad spectrum, which protects against both UVA and UVB rays, and SPF 30 or higher. Apply to all exposed skin, even on cloudy days. Reapply every 2 hours and more frequently if swimming or sweating. Reapply, reapply, reapply. I can't emphasize this enough. And remember to protect your lips with chapstick with SPF. Wear sun protective clothing, which includes clothing with ultraviolet protection factor, wear sunglasses with ultraviolet protection, and wear wide-brimmed hats. And by all means, avoid tanning beds. Remember, they emit UVA rays that we discussed earlier, and there's no such thing as a safe tan. Any tan is a result of ultraviolet rays damaging the DNA of your skin cells. And use of tanning beds before age 40 increases your risk of basal cell and squamous cell by almost 70%. Seek shade. Avoid sun during peak hours, 10 a.m. to 4 p.m. when the sun rays are the strongest. It's very important to perform regular skin checks, including monthly self-exams of your own skin. Think about it. For the most part, you can see skin cancers on your skin, and most are quite obvious and not hiding. You would be the first to notice it. And yearly skin exams by board-certified dermatologists or attend a skin cancer screening like Mary Bird Perkins' Prevention on the Go program that's offered free to the community at many convenient times and locations. For more information, visit marybird.org/skin. And remember, be smart year-round, not just in the summer months. By following these guidelines and using these sun protective measures, we can significantly reduce the risk of developing skin cancer and at the same time improving our skin health. So if we were told at an early age that just by doing one thing and one thing only, and we could almost be guaranteed not to get prostate cancer or breast cancer, we would all do it. But we know that one most important thing for preventing skin cancer, and there is still great reluctancy in wearing sunscreen daily. So these are the excuses or rationalizations that I hear from my patients. I just forget. Some people might simply forget to apply sunscreen, but it's because it's not part of their daily routine. Or they underestimate the importance of sunscreen. They complain about the texture because it feels greasy, sticky, or heavy. The odor. Certain sunscreens have a distinct smell that they find unpleasant. It burns their eyes when they sweat. There's misconceptions. People think they don't need sunscreen if they're not spending extended periods outdoors or if it's cloudy. They may also think that having darker skin means they're not at risk for skin cancer, which is untrue. Then there's cultural norms. Having a tan can be perceived as healthy and beautiful, leading people to intentionally avoid sunscreen because they want a tan. Confusion over sunscreens. With the plethora of sunscreens available now, it can be overwhelming to pick one. But I hope we can clear up some of this confusion today and simplify things. I need my vitamin D. It leaves a white residue on my skin, or my makeup has sunscreen. Isn't that enough? Unfortunately, a lot of these excuses are true, but sunscreen manufacturers have really been paying attention to our complaints, and new formulations are now much more aesthetically pleasing. There's newer mineral sunscreens, which used to cause a white residue on the skin, that are now micronized into small particles and come tinted in different shades, not just light or dark. So they're much more cosmetically acceptable. And they don't burn your eyes when sweating. And now there's also lightweight serum-like formulations and oil-free sunscreens for acne-prone skin. As for makeup with sunscreen, now with these newer formulations, it's a better idea to think of your sunscreen as a makeup primer and apply it first and then your makeup. Now, we've long known that sunscreens work to prevent sunburn, sun damage, and skin cancers, but getting people to wear it daily has been a challenge. By making sunscreens that multitask, feel good on your skin, and are more inclusive of all skin tones, we're getting closer to our goal of making sun protection a daily habit. So let's talk about vitamin D in your skin. There's 3 sources of vitamin D, the first being sunlight. Then there's food, oily fish, cod liver oil, fortified orange juice milk and yogurt, and some cereals. And then there's supplements, which are over the counter and inexpensive. The Skin Cancer Foundation recommends that people should get the recommended 600 international units through food and/or supplements. The ultraviolet rays are cancer-forming, and the harmful effects of ultraviolet radiation far surpass the benefit of vitamin D from sunlight. As I said earlier, picking a sunscreen can be quite challenging. A study done by the Journal of American Medical Association of Dermatology found that almost 50% of people don't understand how to read a sunscreen label or how sunscreen protects the skin. So I thought this would be a good time to brush up on how to read a sunscreen label. Key terms on sunscreen labels that one should understand. Broad spectrum means it protects against both UVA and UVB. SPF, which is sun protective factor, measures how long you can stay in the sun before the UVB rays begin to burn the skin. Example, if it says SPF 30, It allows you to stay in the sun 30 times longer with the sunscreen before getting burned than if you didn't have the sunscreen on at all. Look for water resistant. The FDA prohibits the terms waterproof or sweatproof because it's misleading to consumers. Look for the Skin Cancer Foundation seal of recommendation, which means the sunscreen is both safe and effective. And then check out the active ingredients. This area of the label lists the main ingredients in the sunscreen, and it's often on the back of the label. And there's two main types of active ingredients that sunscreens contain. Chemical sunscreens act like sponges and absorb the sun's rays. Oxybenzone, avobenzone, and octisalate are some of the most common. Physical and mineral sunscreen is the same thing. It's interchangeable terms. They act like shields and reflect the sun's rays. These are zinc oxide and or titanium dioxide. And don't forget to check the expiration date. They have a shelf life of 3 years, especially if stored in a cool, dark space and not left outside or in a hot car. And check the expiration date before buying it to make sure it gives you plenty of time to use it. So putting this all together, when it comes to skin cancer, awareness is truly our best defense. We've learned about the 3 types of skin cancer, identified risk factors and warning signs, explored treatment options, and discussed protection and prevention strategies. By staying sun safe and vigilant about our skin health, we can all enjoy the great outdoors while minimizing our risk of skin cancer. Thank you for attending, and I'll be happy to answer any questions.
Thank you, Dr. Nunnally, for that very informative presentation. Please drop any questions in the Q&A chat right now. While we're waiting for some questions to come in, I just wanted to say that Dr. Nunnally has been practicing medicine for over 30 years, and her passion for skin is contagious. She has always been an advocate for skin cancer awareness and is happy to inform and educate people on these topics. So let's answer some questions. Marie, will we have access to these slides? Yes. The whole webinar will be posted to Mary Bird Perkins' YouTube channel very soon. And let's see. Okay. Can you explain what electrodesiccation is?
Right. That's using a cautery machine, and basically it just burns the skin. And so not only does it stop the bleeding, it gets rid of the precancerous and cancerous cells that are still there.
Thank you, Dr. Nunnally. Is there any more questions? You can drop them in the chat. We'll wait a few more minutes. Meredith has a question. What are some of your favorite brands of sunscreen? She usually uses Elta MD.
Okay, that is one of my favorites. That's a great question. And like I said, there's so much available now. It's very overwhelming. It can be quite a challenge. What you like, the next person wouldn't. So the main thing is do what the Skin Cancer Foundation recommends. Make sure that it's waterproof, broad spectrum, and SPF 30 or higher. Then I direct patients to the Skin Cancer Foundation website at skincancer.org. It's a wealth of information, and it really breaks down the differences in all these sunscreens. When you go to their website, you look for recommended products, and they have drop-down boxes, which then drop down again and drop down again until it finds exactly the sunscreen that's perfect for you.
Thank you. Charity asks, if we are reapplying often, is it worth it to even buy SPF 70 or 80?
No. And the Skin Cancer Foundation is adamant about that. That's a great question because it gives people a false sense of security. That's why they say 30 SPF or higher, but really it's not necessary to go above 50, and it makes it thick and cosmetically unpleasant to wear.
Okay, one more about sunscreen, and then we'll do one more. Sachi asks, is the SPF tint worth it?
SPF tint?
Yes.
Are you asking, is it
Like a
tint?
tinted sunscreen. Yeah, tint is.
Yes. And what that does, especially with the mineral physical sunscreens, not only have they micronized them now, you'll hear about nanoparticles. They've made the particles smaller so that they're not white and pasty, leaving a white residue. But getting a tint makes it even that much more cosmetically elegant, so people will wear them. And now they used to just have light and dark. Now they have all kinds of shades, so there's something for everyone. That's a great question, but it does make a difference to get the tint.
Okay, we'll do this last question. Laurie asks, I've heard about a melanoma vaccine in the news. Is it available yet, or what is it?
That's a great question. It has been in the news, and we've had a lot of phone calls from patients. When people hear about a vaccine, they think it's for prevention. So when they're calling, they're thinking that it's a vaccine that will help prevent melanoma. That would be wonderful, but that's not how this vaccine works. This vaccine is made by Moderna, which is exactly the same technology using the mRNA that's used with the COVID vaccines. But it's not the typical vaccine. It's a therapeutic vaccine that's being used for advanced melanomas with some really incredible results. So it will be available. The results are really amazing because it's used along with Keytruda, which is an immunotherapy. But over a 3-year study, the rate of recurrence and the death rate was improved by 50%. So Moderna is really pushing the FDA to expedite this process to get it available, and they think it'll be available within 2 years. Great question. Thank you.
Thank you, Dr. Nunnally, for sharing this excellent information with us today as we begin Skin Cancer Awareness Month. This webinar, again, will be posted to Mary Bird Perkins' YouTube channel soon. And I just want to thank each of you for tuning in and hope you have a great rest of your day.
Thank you.